R con morre capito, marra cadir que ferro carril. Your tulips coming up yet? Get some tulips. This is Michigan.
I'm just kind of waiting to see it.
Okay, you go to the tulip festival in Grand Rapids and buy them cheap. Yeah, all colors and come up early after the daffodils come up. And line your house with them, with the daffodils.
Yeah.
Oh, really cool.
Yeah.
So your babies are already.
They're starting to blend.
Okay.
I got it.
Cool. We've got some flocks and they're just starting to show they're about a midsummer, so they're just now starting to come up. Flocks and green peas, fire. So they're very well, gang. Hello. Before we get started, I would like to make a request of all of you. Besides my usual request of be good to your parents, please go over your grades on Blackboard. I have been fighting with Blackboard for the last 2 weeks to try to get all the grades in. Sometimes I've noticed I see grades and students can't see them. That sometimes is a prelude to the grade disappearing. So if you have anything for which you have assignments in your hot little hand, please let me know so that they can be re-entered And I will do the ritual of logging out of Blackboard and then logging straight back in and make sure that it's not a logging issue. According to Cynthia Churchwell, they have taken the restrictions on Blackboard and cinched them way down because the school is constantly being confronted with hackers trying to get into our system. So consequently, if, say, I have Blackboard open during class and the system boots me out, but I enter something into the system while the system has booted me, even though I don't know it's booted me, it often doesn't keep the grade. And sometimes it'll boot me without me knowing it while I'm putting grades in, I've discovered. I told Cynthia, that's ridiculous. You're sitting there and putting grades in right after you logged in. The system should not boot you. But the way they have it designed now, it does that to protect against hackers. I'm all for protecting against hackers, but it just seems not. The ignorant about cybersecurity, it seems to me that has to be better. But again, so if you see something that some of you have been very vigilant, and I appreciate that. So please go over your scores and everything, make sure that everything is copacetic. And if there's anything missing, let me know. And if something needs to be, hop along. How you doing? I saw your rehab yesterday.
That's good.
Yeah, no, she was working through the ringer. You were. But that's good. That's what you want. How's it feel? Of course. Is your range of motion getting better?
Extension, no, but flexion, yes.
That's the first thing you want. Good. Good. You're right on target.
Yeah.
You're walking great.
Mhm.
Great. You think you'll be able to go without breaks pretty soon, or?
They probably said it's at least another month, they're hoping.
Okay.
I can go without it if I really need to, but no reason to.
Cool. Well, very good. Very good. Glad to see you back in the saddle. But grades, yeah. Please go over your grades, make sure everything is as it should be. If it's not, let me know. You may need to resend some things. I've discovered I don't always get your guys' email. I don't know why, but I don't sometimes. I know one of you has sent me something at least 4 times that I still haven't gotten. So again, I have no explanation for these things. So it happens. So do check your grades, make sure everything's there that should be there. And I will trust you to be honest and not try to say, oh, you didn't give me a grade for this assignment, I never turned in. So that's on you. I got a call from Mindy, so after the semester, we're supposed to all have a palaver about the meeting, about you all and your matriculation to the nursing program. So I think all of you are terrific, so I don't think any of you have anything to worry about. I've been singing your praises as high and as hard as I can. And no, I'm not very bribable, so just in case you're wondering. All right, so back to what we were talking about. Rheumatoid heart diseases have a very strong genetic component. The one in particular you will almost see the most in your practice is rheumatoid arthritis. In this case, you have the chemical modification of amino acids of various proteins in the joint. You have the deamination of arginine to citrulline. That's called citrullination. This is due to this enzyme called peptidyl arginine deaminase. That peptidyl arginine deaminase is produced under cases of stress and what have you. However, in people with rheumatoid arthritis, their tendency to produce this enzyme is higher. Also, because of their genetic propensity, their immune system will react to these citrulliнаted peptides, whereas in someone who does not have the genetic predisposition for rheumatoid arthritis will not react to those types of peptides. So genetics plays a really strong role. Consequently, you're going to see things like antibodies to citrulline protein antigens, so-called ACPAs, About 95% of rheumatoid arthritis patients will have antibodies to citrullinated protein antigens. These tests are pretty easy to do in the lab. Rheumatoid factor is not specific for rheumatoid arthritis. So other autoimmune diseases where you'll see rheumatoid factor. Remember, rheumatoid factor is an IgM. It's an IgM that binds to the FC portion of other IgGs. These will tend to precipitate out in joints and further, further the immune response within the joint. So as a consequence, essentially, of what goes on in the joint, you have the presentation of those antigens to, you have presentation of those antigens to the immune system. You have T helper cells, well, dendritic cells, take them to lymph nodes, they present them to T helper cells. The T helper cells will then secrete gamma interferon, interleukin 17, and then they recruit macrophages, and the macrophages, these are so-called M1 macrophages, those are the pro-inflammatory macrophages. They secrete this formidable cocktail of pro-inflammatory cytokines, and they cause the synovial cells to proliferate. They differentiate into this thing called pannus. The pannus then actively erodes the articular cartilage, and also the bone. If it gets through the cartilage, it'll actually erode the bone as well. These cytokines also get distributed systemically, and you have systemic symptoms. This differentiates it from osteoarthritis. Osteoarthritis does not cause systemic symptoms. Does not cause systemic symptoms. Yes, inflammation plays a role in osteoarthritis, but it's local. It's local. Here, the reaction is systemic. Systemic. So here's an example of a pannus doing its thing. I think, okay, there, better. Here you see the pannus, you clearly see this is different. See how cartilage looking that looks? See how non-cartilage looking that looks? See how it's eroding even into the bone and causing all kinds of mischief over here and what have you. That's an example of a pannus, kind of hard at it, further degrading the tissue. And then you get the formation of blood vessels where there should not be blood vessels. Do you see many blood vessels in cartilage?
No.
No. That's one of the reasons why cartilage is poorly regenerative, at least articular cartilage, regenerates rather poorly. These new vessels also are going to take those pro-inflammatory cytokines. They're going to affect other organs. The big ones, of course, are the skin and also the lungs. Those aren't the only organs that can be affected, but they will be responsible for the extra-articular manifestations of rheumatoid arthritis. So skeletal muscles can be affected. Blood vessels can be affected. That increases your risk of atherosclerosis. You have iron storage is increased. It's increased. Hepcidin levels go up because of the cytokines. Now the iron is sequestered inside macrophages and liver cells. You now have something called anemia of chronic diseases. You have plenty of iron, but it's stored. And hepcidin also prevents absorption of iron. So you see this with diseases with chronic inflammation. You see that in particular with active rheumatoid arthritis. You get fever as a result, particularly of interleukin 1, but also interleukin 6. You can also have uveitis of the eye. And then also you can involve the sclera. Sometimes, rarely, you get Felty syndrome, where this triad of rheumatoid arthritis, neutropenia, and the spleen gets enlarged as well. Here's a lung with rheumatoid involvement, you can see the nodules in the lungs. This can cause scarring of the lungs, a term, you heard it last year, but it might not be fresh in your memory. Pneumoconiosis. So pneumoconiosis, ring any bells? No? So pneumoconiosis, you get damage to the lungs. That damage is replaced with collagen. The collagen causes restriction of the lungs. The lungs cannot expand and contract as they should. That's pneumoconiosis. You see that a lot in pulmonary, where the lungs are filled with particles that the macrophages can't handle. So in response to that, you get fibroblasts that are activated to make collagen. Pneumoconiosis is a potential side effect of uncontrolled rheumatoid arthritis. Okay. Over here. Yeah. All right, so it also will affect the joints. So over time, the joints have become very stiff. They'll become particularly stiff in the morning after being inactive for a prolonged period of time. That stiffness will decrease with activity, with use. That's the opposite of osteoarthritis. With osteoarthritis, the more you use the joint, the more it tends to hurt. Because as you use the joint, you tend to increase the damage. Can't see a thing now, can you? You know, I think the worst culprit is this one here. Well, that doesn't help much either. That good? Okay. Keep that. All right, so looking at the hands of this individual here, you start to get specific deformities, and the first joints that tend to be involved are the metacarpophalangeal joints in the hand. You'll also get, you'll tend to see effects on the wrist. The fingers will tend to move away from the thumb. You'll get kind of a hand that's kind of like that. You'll get deformities also in the interphalangeal joints. You can kind of sort of see those here, although you don't see them on an X-ray, where you get the so-called buttonhole deformities. That's sometimes called the Boutonnet deformities, where the erosion of the bone and the distal phalange causes it to kind of look like a button. That's a buttonhole deformity. The extensor tendons in the back of the finger splits, and the head of the proximal phalange will poke through like a button. That causes a flexion of the proximal interphalangeal joint. So essentially the joint now will come up like this. That's called a swan neck deformity, a swan neck deformity. So the finger deformity, you get the swan neck deformity. You can also have sometimes hyperextension of the proximal interphalangeal joint and then flexion of the distal interphalangeal joint. The hands are one of the first places where you'll typically see the effects of rheumatoid arthritis. In the knee joint, you essentially have fluid from the knee, and because the knee, the synovial membrane gets so thick, it now becomes kind of a one-way valve. Fluid can go in, but it can't drain. So fluid from the swollen knee will fill the semimembranous bursa, and the sac can get so, the synovial sac can get so swollen, it'll actually bulge into the popliteal fossa, creating what's known as a Baker cyst. Soccer player. Bree. Baker cysts are really common in soccer players. Have you ever had friends with a Baker cyst? Baker cyst, if you feel them from the back, the ACL gets swollen. And okay, you've had that. Okay. Anybody else play soccer? Yeah. They so the ACL, the back part of the ACL will get damaged, swells up a little bit. It's reversible, but when it can really hurt because it feels like you've got something in your knee. You feel the back of it, and that's called a Baker cyst. So with rheumatoid arthritis, you get a Baker cyst, but it's synovial fluid that gets forced through the popliteal fossa. And that will cause a popliteal cyst or a Baker cyst. It's not so much due to the destruction of the ACL, it's due to that extra synovial fluid. And if you feel a Baker cyst, say from an athlete, it's hard. Whereas you feel a Baker cyst from a person who has rheumatoid arthritis, it's soft, it's pudgy, because it's full of synovial fluid. Yeah, those hurt.
I played soccer all of high school and I stopped in college, but towards like the end of my soccer career, I would always, my back of my knees always be so swollen, and I never understood why. And it was like hard, like you said, and I was like,
Yeah, it's a Baker cyst. And Bria, I bet you've had friends who've had that. In fact, it gets so big sometimes you can actually see it in the back of the leg. If you have someone, you wouldn't see it in me, my legs are too fat, but someone with slender legs, if they straighten their leg out, you'll actually see a little bulge sometimes. And if you push on it, they go, ow. Yeah. Rest will usually it'll heal and it'll go away. You can also have involvement, of course, of the feet. Take a look at this X-ray. You'll learn more about interpreting X-rays in your other classes, but you see the erosion here? Kind of like somebody took a bite out of it. That's really common. And then you'll notice how you see the little kind of vesicles here like that. Those are cysts. Those are interosseous cysts. And they're the result essentially of damage to the bone, where the bone's been hollowed out, the bone may be trying to regenerate. And these cysts, they can merge and you get stuff like this that's really disconcerting. See that? It's like somebody went, you got hungry, essentially, and had some bone for breakfast or something. And then see the bone here? See how dense this bone is and see how non-dense? Also, what do you see here? That look normal? That's called an hourglass phalange. An hourglass phalange. That's really common in rheumatoid arthritis. The erosion essentially goes both ways, so the thing kind of looks like an hourglass. You can see that over here too. Really common in the foot. So blood tests, you're going to look for the antibodies against the citrulinated peptides, and then also you're going to look for the citrulinated peptides themselves. Rheumatoid arthritis patients, 70% of them are positive for the rheumatoid factor. And then the anti-cyclic citrulinated peptide antibody is an antibody that targets the citrulinated proteins. These are more diagnostic. 95% of patients will have a positive ACPA or CCP. Also, X-rays are important. Imaging will be very important to be able to see. You can have patients that are negative serologically, In cases like that, your diagnosis will be based solely on clinical findings and imaging. In some cases, you can do something called arthrocentesis. Arthrocentesis simply means withdrawing synovial fluid using a needle. You then examine that fluid under a microscope. You can do that to rule out septic arthritis or something like that. Also to rule out gout, because you can see gout crystals in cases like that. Cases where you have rheumatoid arthritis, you're going to have lots of white cells, usually inside the synovial fluid. So treatment is with the disease-modifying anti-rheumatoid drugs. The usually drug of choice is methotrexate. That's a folic acid analog. It inhibits dihydrofolate reductase. Dihydrofolate reductase synthesizes tetrahydrofolate. Synthesizes it from folic acid. Dihydrofolate reductase. Methotrexate is going to put the kibosh on that enzyme. It's going to prevent cells from making tetrahydrofolate. Tetrahydrofolate's involved in single carbon transfer reactions. These single carbon transfer reactions are incredibly important for the synthesis of DNA and RNA. Without tetrahydrofolate, you cannot make DNA or RNA. Therefore, cells that expand, like immune cells, can't expand. So you don't get the inflammation, you don't get the expansion of macrophages and B cells and T cells and what have you. And this will therefore suppress the immune response. That's methotrexate. At low doses, like you usually use for rheumatoid diseases, methotrexate is pretty well tolerated. Side effects that can occur include pulmonary fibrosis, hepatotoxicity, sores in the mouth, otherwise known as stomatitis. Hepatotoxicity, stomatitis, and nephrotoxicity. Methotrexate can lead to folate deficiency. What happens if you don't have folate? What happens to your blood cell production? Yeah. Remember that from pathophys? What's the main cause of megaloblastic anemia? Folate and B12. So absence of B12 or absence of folate can cause megaloblastic anemia. There's a nice way to prevent that. You use a compound called leucovorin. Give leucovorin with the methotrexate. Leucovorin is sometimes called folinic acid. So it doesn't require dihydrofolate reductase to be metabolized. It will prevent the anemia, but methotrexate will still tend to work. The big downside of methotrexate is very teratogenic. Can't use it in pregnant women, can't use it in women who are breastfeeding either. So if methotrexate doesn't work, or if it is contraindicated, we don't have any more pictures. So then you can use some of the other drugs listed up here. Hydroxychloroquine is definitely the safest of this group. It's also the drug of choice for women with rheumatoid arthritis who are pregnant. It's safe during pregnancy. This drug inhibits the immune response through multiple mechanisms. Sulfasalazine is converted by colonic bacteria into its active form. It's pretty safe, but it can cause malaise. What's malaise mean? What's that mean? Sorry? Discomfort? No. You're dead dog tired. You're tired. You're worn out, like after my farm class at night. Many of you have malaise. In fact, a lot of you have malaise when you walk in, but your malaise is worse when you walk out. So malaise, you're worn out, you're tired. Malaise could cause malaise, nausea. In guys, it can cause oligospermia, low sperm count. That's reversible, fortunately. And if you're allergic to sulfa drugs, it can cause sulfonamide toxicity. Then there's lefonamide that inhibits an enzyme involved also in nucleotide synthesis. It suppresses T cell proliferation. It unfortunately is quite teratogenic, and it can cause diarrhea, hypertension, and hepatotoxicity. So that one you can't use if you're pregnant either. At low doses, these drugs are usually fairly well tolerated. What if these drugs don't work? Then you go to a biologic DMARD, a biologic DMARD. So there are drugs that will inhibit tumor necrosis factor. These drugs tend to be antibodies. If they end in MAB, they are monoclonal antibodies. So certolizumab, adalimumab, golimumab, infliximab, all of those are antibodies. Etanercept is a tumor necrosis factor receptor that's soluble. So it binds tumor necrosis factor. It's like a dummy receptor. And it withdraws tumor necrosis factor from circulation, preventing it from activating the inflammatory cycle. All of those are anti-tumor necrosis factor drugs. They're relatively expensive, but they work quite well. Always keep in mind before you give these drugs, you have to give somebody a tuberculosis test because they can activate latent tuberculosis. Beyond that, they're fairly well tolerated. If those don't work, then you move to the interleukin-6 inhibitors. Tocilizumab, sarilumab, these were used to treat patients with SARS-CoV-2 successfully. In the later stage of SARS-CoV-2, where you have the cytokine storm, those drugs are also used in cancer patients being treated with anti-cancer drugs that kill a lot of cancer cells because that can cause cytokine storms as well and tocilizumab actually made its debut as a drug to treat cancer patients experiencing cytokine storms. JAK inhibitors, these are oral. These are small molecules that inhibit the Janus kinase. That's important for immune cells. These drugs, unfortunately, have a lot of side effects. So they're definitely used kind of third string, and then kind of other honorable mentions that are used as well. Drugs that are anti-interleukin-1 includes anakinra, and then canakinumab. Anakinra has a pretty good track record with rheumatoid arthritis. Canakinumab has been used successfully, but it's a newer drug. There's not quite as much data on its success. So adalimumab is Humira. Humira is widely used by lots of rheumatologists. Pretty well tolerated. Pretty well tolerated. And as you can see, it's given subcutaneously, and it comes with an injector pen that patients can give themselves. They don't need to go to the doctor to get their medicine. So the rheumatoid arthritis susceptibility genes, these are genes that map to the major histocompatibility locus. They encode so-called human leukocyte antigens. These are surface proteins on the surfaces of white blood cells. There are particular alleles of these genes that are listed there. If you have these, your chances of having rheumatoid arthritis go up substantially. The reason seems to be is that these proteins are involved with antigen presentation. Particular alleles of these genes encode antigen presentation proteins that do a better job of presenting the citrulline, the life of me, I can't say that word easily, citrulline polypeptides. There's been a good deal of lab work on this. This hypothesis turns out to be probably correct. Probably correct. So, family history is going to be quite important. There are genetic tests that you can order for these. You will order them in a panel. And if someone comes back positive for these particular alleles, they have an increased risk for rheumatoid arthritis and they should be watched. Right now, as far as I know, the American Society of Orthopedists, American Society of Rheumatologists do not recommend scans because you're exposing people to more radiation, perhaps for no reason. If they start to have symptoms, then it's recommended that they have scans. Any questions about rheumatoid arthritis before we move to systemic lupus erythematosus? Systemic lupus erythematosus also causes arthritis, but the arthritis it causes is secondary to the sorts of things that it causes. So systemic lupus erythematosus, otherwise known just as lupus, is higher among Asians, African Americans, African Caribbeans, and Hispanic Americans when compared to Caucasians. The female to male ratio is 3:1. Female hormones seem to play a significant role in its pathology. People of Northern European ancestry will tend to have the so-called discoid skin lesions. That type of lupus is not as severe as the type you get with the verrucous types of skin lesions. And those show photosensitivity. This is a biggie with people with lupus. They must protect themselves from the sun because the sun is usually a trigger for people with lupus. The sun will usually cause them to get sunburned and they'll get a flare, usually. So protecting themselves with sunscreen and wearing proper clothing and hats and gloves or whatever else, very, very, very important. So in women of childbearing years, you can see that ratio goes from 3:1 to 7:1 to 15:1. That underlies the role of female hormones in the initiation and pathogenesis, pathophysiology of lupus. The susceptibility genes, many of these are X-linked. And there are things like this encodes the receptor for interferon, and then other types of genes. This is a gene for a toll-like receptor. This is one of those pathogen-associated pattern receptors, and then macrophage-specific protein receptors, things like that. There are several proteins involved with proteolysis of unwanted proteins, alleles of which increase your risk of lupus. People with Klinefelter syndrome have a higher, that's supposed to be rate, sorry, higher rate of lupus. This suggests that gene dosage plays a role. There's a much lower rate in people with Turner syndrome because they have a lower rate of gene dosage, lower amount of gene dosage. So-called genome-wide association screens have been done. As you can see, there are several genes involved with lupus. Consequently, doing DNA testing for people with lupus is not going to be very informative because there are almost certainly genes that haven't been associated. Also, you can have alleles of several genes that interact. That seems to raise your risk of lupus. And then there's the environmental factors too. So family history will be important, but there aren't genetic tests you can order for lupus. Sorry. This is just to show you that in terms of genes involved with the onset of lupus all over the place. What causes lupus? Lupus seems to be caused by damage to cells. Those damaged proteins are taken in by the cell and they're degraded by the proteasome. However, in people with lupus, those proteins don't get degraded all the way. So then the cell takes them and presents them on the surface of the cell. The immune system recognizes them as foreign and reacts to them. And many of those proteins are things from the nucleus. That's why people with lupus will have antibodies against nuclear protein. And one of the antibodies that can be diagnostic for people with lupus is the anti-nuclear antigen. Excuse me, anti-nuclear antibodies, or ANA. ANA tests, they're not specific for lupus, but if you have positive ANA, that's a pretty good sign that you either have lupus or something like it. The manifestations of lupus vary wildly from patient to patient. Some will show involvement mainly with the skin. They get the so-called butterfly rash, malar rash, usually after they're exposed to the sun. Others have involvement in the joints. They get arthritis. It's a polyarthritis of several joints. Others, they get what's called Lippmann-Sachs endocarditis. The lupus is manifested in the heart. Others, it's in the kidneys. And then my old colleague, Chris Newhouse, his wife, her lupus was completely concentrated in her liver, and her liver failed, and she needed a liver transplant. It was only by the grace of God that a dying friend's son died, and before he died, in a freak car accident, said, "You must give my liver to Kathy Newhouse." And now Kathy Newhouse is a picture of health because she now has a new liver. So the manifestations of these diseases vary completely. So while there are particular lists of things you might see in a lupus patient, you're not going to see a typical lupus patient. Every patient is individual. You must treat the patient as an individual. Medications are going to be the same sort of immunosuppressive medications we saw, except there's one medication that gets used the most, as hydroxychloroquine. That's one that gets used the most. Now, for a patient perspective on lupus, I've asked someone who has some experience with it. Great. Come up here and tell us about your experience with lupus. And thank you, by the way, for volunteering to do this.
As you said, I do have lupus. I've had it since I was about 8. They actually found it on accident when I was 14. I went in when I was 8 years old in the hospital with about 105. Turns out I had strep throat, and that was about it. My white blood count cell was really low. And so I had to have a bone marrow transplant
at that point, and so that kind of started like when I called my medical journey. For me, nothing ever shows up in any of my blood work, except for the fact that I have an abnormal white blood cell count and my bilirubin is always small. Other than that, I don't show anything else in any of my lab work. They actually found an accident. They thought that I had like leukemia, breast cancer, brain cancer, the whole list. But they found it on a lymph node biopsy. Turns out like the gene sequence lined up, and so that's how it kind of came about. And so now that I'm older and getting more hormones, as he said, like I am doing further testing and stuff like that to try and decide my next course of action. But for me, it's been pretty manageable with diet. My lupus affects my liver, so I don't eat a lot of fatty foods. If I do, I just plan it out like one fried food meal a day, or I just have to be careful. I don't notice it too much in the sun unless I'm down south, because I have more tan skin. I don't get sunburns, so I don't have to worry about that. But if I stand out in the sun for a long time, it's really hot, I do get the butterfly rash. I always have sore joints, and by the end of the night, you'll see me standing here like this because I can't really move my hands. So that's pretty common. I have definitely become hypersensitive to my body and it smells. Like I get this really weird sharp pain in the back of my shoulder, and that's how I can know that I'm starting to eat too much fat. And I just have to be careful of what I eat for the rest of the day. I do have like some medication for when I eat too much. And my liver goes really bad. I have 2 different types of flare-ups. First one can be caused by sun, or it's just like more of a lupus-based flare-up. And I also have one that if I eat too much fat, my liver goes really pooped. So that could be like anywhere, it lasts anywhere between like an hour to 2 hours. Usually either keel over the toilet puking or just in a ball and a lot of pain. I do sometimes pass out from the pain, so it just depends. But I can kind of tell if they're coming. So that's how it is. For me, I had never seen it as a crutch. Like I had it since I was a kid. My parents sat me down and they said, never use this as a crutch. Like never use any excuse or anything like that. So for me, like the fact that I'm playing sports right now is kind of crazy because I was told I'd never be able to play like past middle school because I would slept like 14 to 16 hours as a kid because I'm so tired all the time because I kept fighting off so many different things. But like for me, it's like you just kind of see it as an obstacle and you try to get around it. So trying to sleep more, eat healthy, and as I get older, it definitely gets worse, but you kind of find triggers and stay away from them. So yeah.
Does anyone have any questions?
Oh yeah, you do. I'm totally fine talking about this. I think it's cool. So
When you say your bilirubin's off, by that you mean high?
yeah.
Higher than normal?
Yeah. Weird.
Can you feel it when your bilirubin is high?
I'll go jaundice if you can tell. Like whenever I eat too much fat, I'll get yellow. So it'll go away, but
I've noticed.
You
once
can
or
tell.
twice, yeah.
oh yeah. Pretty bad. I can usually catch them early. Like I can tell I'll get a pain here, or I'll get like a burning in the middle of my stomach really bad. That happens like I just chug water, I sit with the heating pad on, so I can usually try to catch them early. But it's,
Does your skin itch when?
I don't notice too much with my skin, thankfully. Besides the butterfly rash when I'm in the sun, that's about the only skin I get. But I definitely, my joints have been getting bad. I'll sit there and go like this all day.
It's your upper body, not your lower body.
In my feet sometimes. I do have weird discoloration in my legs. Sometimes they'll go blue. That does happen apparently. It's related to lupus.
Yeah.
So,
Any more questions?
So are you not able to get like vaccines?
yeah, some of them I haven't been able to get. So when I do a lot of traveling, I don't get anything considered live. So I never got any of those. I did talk to my doctor about the COVID vaccine and I did not get it because I had really bad reactions to a lot of the previous ones. He said that we could try the first one and see how it goes, but we kind of sat down and weighed a lot of the options, and this one for me, I already had it at that point, and I did get COVID really bad. I slept for like 36 hours straight. It was pretty bad. Yeah, but thankfully I didn't have to be hospitalized for it or anything. I took a lot of antitoxins, and we were able to kind of beat that through that. So I don't usually get the flu shot every year. I've gotten like my TB, anything considered dead. So yeah.
I think it's really powerful when someone can talk about some sort of illness they have. I just think that's really cool when someone can do that, especially talk as fluently as Bree does about it. All right, let's talk about a different genetic disease. This is an inherited form of cancer, and it is called neurofibromatosis. This is a particular genetic disease that wipes out a tumor suppressor gene. We talked a little bit about what tumor suppressor genes do. Does anyone remember many weeks ago we talked about 2 different types of genes that can lead to cancer when they undergo mutational changes? There are the genes that drive growth, they're called
Oncogenes.
proto-oncogenes, and then when they undergo gain-of-function mutations, they become oncogenes. Then there are those that put the brakes on cell division. Those are called tumor suppressor genes. And loss of function mutations in tumor suppressor genes can give cells a growth advantage and cause the production of tumors. This is one of those genetic diseases. So these conditions here that we'll talk about, these are due to loss of function mutations. Loss of function mutations. They cause tumorous growth, non-cancerous growth in nerve tissue. Nerve tissue. There's 2 types, neurofibromatosis type 1 and type 2. Type 1 and type 2. So these will be inherited. They'll be recessive, autosomal recessive, but you inherit the autosome, you inherit the recessive mutation. As you grow and develop, your neural tissues can, with growth and development, get a second mutation in another copy. So inheritance-wise, they look like dominant mutations, the way they're inherited, even though from the cell biology perspective, they're recessive. So the NF1 gene, mutations in which called neurofibromatosis 1, that's found on chromosome 17. And the NF2 gene, mutations in which cause neurofibromatosis type 2, is on chromosome 22. So NF1 encodes something called neurofibromin, and NF2 encodes a protein called Merlin. Merlin, after the wizard in the Arthurian stories. So you see this in about 1 every 3,000 people. So it's more common than cystic fibrosis, more common than Huntington's disease. It's more common than you think it is. So its inheritance pattern is autosomal dominant, even though from the cell biology perspective, it is a autosomal recessive. So a child needs but 1 faulty copy from a parent to get the disease. Again, the tumor suppressor genes, if you knock them out, cells will now start to grow uncontrollably. So what happens if you don't have proper NF1 or NF2? You get uncontrolled growths that are called fibromas. Fibromas. If you look at these fibromas, if you dissect a fibroma, you find something really curious. They're full of multiple different cell types. They have neurons, and those neurons will actually be like neuroblasts that are dividing uncontrollably. They'll have Schwann cells. What are Schwann cells? You have to speak up. I don't hear that well anymore. Nerves that have to transmit their nerve transmission really quickly. What do they have wrapping them? Myelin sheath. What makes myelin sheath? Oligodendrocytes in the central nervous system. In the peripheral system, it's Schwann cells. Schwann cells. And then you'll have connective tissue, fibroblasts, other things like that. So these masses tend to be associated with nerves. And they contain multiple different cell types, which is frankly quite curious. Now, if these growths are around nerves, you think they can impinge on nerves and prevent nerve function, interfere with nerve function? Yeah, they can. They can. So the type 1 neurofibromatosis also gets called von Recklinghausen syndrome, and it will tend to affect nerves in the extremities and in the skin. Extremities and in the skin. So these are benign tumors of the myelin sheath. They're mixtures of all these different cells, Schwann cells, fibroblasts, immune cells. They usually grow just beneath the skin surface, but they can also grow along peripheral and also spinal nerves as well. So the cutaneous neurofibromas, they're going to start usually in childhood. They'll increase usually gradually over time. They're usually not painful. They're mobile bumps under the skin. If you feel it, oh, it kind of moves when I push on it. They're soft too. They're not hard. They're softish. Now, on top of that, if you look at their skin, they have these cafe au lait spots. Those patches, they look like the color of your latte, essentially, when you come out of Starbucks. So black coffee looks like nice black coffee. Once you put all that cool milk in it, what's it look like now? Right, kind of a tan color. That's what you're going to see with kids usually with neurofibromatosis 1. These little spots on their skin, usually you'll see them on the back. You can see them on the gut, chest, gut as well. But they're kind of a tannish color. Kind of a tannish color. So if someone has light skin, let's just pick on Sydney, since she's a lighter hue, she'll have little tan spots, essentially over her part of her body. You get someone of a slightly darker hue, like Bree or like Emily here, they're going to have actually little discolorations in their skin. It look like spots went on. I tried to tan that little tan, essentially. That's what it's going to look like.
Does it look like mold or like?
It can. It can be mistaken for pityriasis, that skin yeast that makes a little discolored spots, pityriasis. It can look like pityriasis. It's often mistaken for pityriasis. So yeah. So these spots, these cafe au lait spots, they'll appear on the back, they'll appear on the tuchus, they might appear on the thighs, and they will increase in number over time. That shouldn't happen. If you do an eye exam, you're going to see what are called Lisch nodules in the iris of the eye. Can we agree that doesn't look normal? That is pretty diagnostic for neurofibromatosis type 1. They don't tend to cause sight problems. You'll see these usually arising around 6 years of age. People with not very severe disease, it may arise a little bit later. When you see those in an eye exam, you don't need special equipment to see this, just your ophthalmoscope. Right on the eye, you can usually see those. Now, because you get these, because you can also get these lumps in the brain, they can impinge on blood vessels in the brain and also on neurons in the brain. So they can cause seizures, they can cause learning disabilities, because you have these sheath tumors, and if they continue to grow, they can become malignant. The skin ones can be removed very easily. Ones in the brain, it's a little harder to do. It's a lot harder to do. If you get large ones that appear in the abdominal cavity, they can obstruct, impinge, and push on organs like the kidneys and whatever, and they can interfere with their function. Here's an example of these cafe au lait spots on the back. And here's what multiple tumors look like. That's, I think we agree, is a pretty severe case. So the skin, freckling, tumors of varying size and frequency. That picture I showed you, of course, is a very severe case. In the digestive tract, you'll have pain, vomiting, chronic constipation and diarrhea in the skeletal system. You may have sort of arthrosis, bone deformities, scoliosis, things like that, and what have you. You might also, because if you're interfering with the kidney, have high blood pressure. If you interfere with the gonads, you might have earlier delayed puberty. And in the eyes and face, these can be unfortunately rather disfiguring. They can impair vision, they can even cause blindness. You can have optic gliomas and also the Lisch nodules. Lisch nodules are pretty inconsequential, but the optic gliomas are not. So you can have developmental issues, and the list is here. You guys can read, I don't need to read all those to you, but this essentially is a result of poor nervous system function because of tumors that pop up in the central nervous system and interfere with the brain working. Type 2, on the other hand, instead of affecting the skin and peripheral nerves, is going to tend to affect the brain, spinal cord, and cranial nerves. So the cafe au lait spots are less common. You tend to get things called schwannomas. They're comprised only of Schwann cells. You don't see the mixture of cells like you do in type 1. These will develop along the spine or along the cranial nerves. There's one right there you can see in this MRI. Over there, can you see that all right? It's pretty hard to miss. And also acoustic neuromas that develop along or in the 8th cranial nerve. They're, of course, going to cause usually ringing in the ears and then gradual loss of hearing. And these tend to occur usually on both sides. So you get loss of hearing eventually in both ears, but not always at the same time. And then meningiomas as well. And you can see these here. These are tumors of the meninges. These can be unfortunately invasive. They will compress the spinal cord and cause paralysis, weakness, what have you. The meningomas can cause seizures, visual changes, muscle weakness, and they can have eye problems, cataracts, hamartomas of the retina and things like that, what have you. It's, yeah. So typically with these, you'll have tumors along the 8th cranial nerve, that's the acoustic nerves, meningomas, ringing in the ears, bilateral vestibular schwannomas will affect hearing balance. If you give them a rhomboid test, where you have the patient stand like this and close their eyes and what have you, they will, that sort of thing, they won't be able to pass a rhomboid test. Cataracts at a young age, spinal tumors, balance problems, wasting of the muscles because of interference with the motor cortex. You diagnose these usually with imaging. There are very good genetic tests to identify mutations in NF1 or 2. If you order a test, NF1 and 2 genes will be tested in a panel. No specific treatment. Surgery can remove the tumors that are compressing the nearby organs. That's pretty much it. Some of the companies that provide genetic tests for neurofibromatosis include Ambry Genetics and Invitae. These are ones that do specialty tests, which you can order for patients. And if you do peds or some family medicine, you'll probably see a few places. Questions? Very good. Don't forget, we have a quiz on Friday. I welcome your questions on Facebook as usual. And I will see you all later.